Thank you, Carmen. Thank you, everyone, for coming. It's so great to be here, and hopefully my slides will pop up at some point. But it's really wonderful to be in a room full of folks who have such a deep understanding of the physiology of ME/CFS. I've been on this wonderful sort of tour through Norway to Vienna, now in Berlin, just meeting with experts on ME/CFS and Long COVID and other infection-associated chronic illnesses. I was asked today to talk about, sort of how I got involved in this research and what the pandemic has taught us, some of the research that has happened in the last 5 years as a snapshot that I think is particularly helpful and relevant to the field. Just by way of a bit of a recap, this is a photo of Central Park and the Upper East Side in New York City in March of 2020, just outside of my hospital, the Mount Sinai Hospital in New York, where this was the sort of overflow of emergency department that was occurring because of the SARS-CoV-2 pandemic. And as more and more cases were entering into the hospital, this is the atrium of Mount Sinai Hospital being retrofit to become ICU beds because we were running out of beds. And the reason I'm telling you this is because we had such an influx of thousands and thousands of patients, and we had this terrible acute COVID choice of telling people that they were either too sick for home, so we had to admit them, or they were not sick enough for the hospital. But we didn't really know anything about COVID at the time. So we would say, go home, and if you get sicker, come back. But then the patient would say, well, how much sicker is sicker, And we would say, we don't really know. So my team does a lot of remote patient monitoring as part of other projects that we work on that are not related to infection-associated chronic illness. So we had a lot of remote physiologic monitoring technology. So very, very quickly, what we did was we integrated into all the emergency departments, and we just sent out an app-based questionnaire. So when someone was told, you're not sick enough, go home, now they were told, you're not sick enough, go home, and someone's going to monitor you every day. They're going to take your blood, your SpO2, they're going to ask you how you're doing, they're going to check your symptoms. We had a very sort of structured protocol. We even had it down to the number of minutes that we would spend with each patient every day. And this, our first patient was onboarded onto this platform of March 17th, 2020. So we were moving fast, and we were able to have thousands of people being monitored on a daily basis. And it allowed us to start to categorize acute COVID symptoms. We even produced some of the first data showing that symptom profiling was pretty much the same, whether or not you were PCR positive, PCR negative, or just PCR unknown, indicating that the tests weren't perfect, but people were getting sick, and people were getting sick in the same way, and we knew how to triage and monitor that. And it also allowed us to understand that around 15% of cases at the time of these 7,000 people that we were monitoring were starting to develop persistent symptoms. And so this is actually one of our first papers that we pre-printed and we never published, kind of out of protest, because when we tried to publish it, a certain journal that won't be named, +1, said, oh, you can't call this an emerging syndrome because we called it post-acute COVID syndrome. They said, you can't call this an emerging syndrome because all you have is the patient's word that they're sick. You have no biomarker. So that was the earliest critique that we got in, it was probably May of 2020 when we sent this in for peer review. So at a certain point, we were going back and forth arguing with the editor, and then we said, you know what? Our preprint has already received more citations than your journal's impact factor. We're not going to publish with you because you guys are acting in bad faith. Because eventually they said, we'll publish it, fine, because they saw it was getting media attention. And we said, you know what? No, you don't get this publication. We're just going to keep it on preprint. So the point was we were seeing these symptoms. As you all know, we've learned that there are a few more symptoms since then. This is long COVID is this very diffuse illness. It affects every single organ system. over 200 symptoms can be associated with the diagnosis. And so we're learning more and more. And the main reason we felt the need to dig into this was, all of these patients were saying to us, okay, well, how are you going to treat us? Like, it's all well and good for you to catalog all of our symptoms. How are you going to treat? And I will confess to everybody here, at first, my sort of dumbass rehab brain was like, well, this is just concussion. This looks a lot like concussion. So it's probably going to be POTS. It's probably going to be a little bit of systemic inflammation. We'll have this wrapped up. We know how to treat concussion. We'll have this wrapped up. Thankfully, at that point, really smart people started reaching out to me and talking to me and saying, you're very stupid, but it's not like that. It's not that simple. But let's see if we can teach you. And that was people like Amy Prohl, who was teaching me about persistent pathogens. It was people like Akiko Iwasaki teaching me about the immune system, which I swore I would never study again. And, we started to do some research into pathobiology. As we start to sort of move forward, this is a really nice paper that was published by Hannah Davis and her colleagues in 2023, showing some of the most likely underlying drivers of long COVID pathology. And what you can see here is, you can see immune dysregulation and viral persistence. You can see gut dysbiosis. You can see autoimmunity. You can see endothelial dysfunction, clotting disorders, things like microclots that Riccia Pretorius has been publishing on. And you also see nervous system dysfunction. Our job is to really sort of try and understand how these are linked, how these drivers are linked, which drivers drive other drivers, how these drivers change over time, and then how we can treat some of these drivers to actually make a difference in people's symptoms. But I want to take a little bit of time today as sort of an overview of the field to just talk about the work that has been done, which very concretely proves that these physiological drivers are all valid, maybe not in every single patient, but they're certainly valid in a subset of patients, which really pushes the need for personalized medicine and personalized approaches to care. I want to sort of shout out this paper that was led by our scientific director, Dr. Amy Prohl. She led this review in 2023, which really pulled together this wonderful, comprehensive analysis of all of the studies to date that have shown that viral persistence, SARS-CoV-2 persistence, is objectively real in people with long COVID. So in a large proportion of people with long COVID, again, maybe not everybody, but at last count, at least 40 to 50% of people with long COVID have some evidence of persistent antigen or some sort of biomarker of persistence circulating in their body. So we do know that persistence of the virus has a central role in pathobiology. However, we also know that the SARS-CoV-2 virus has this knack, and so do other viruses, has this knack of reactivating other viruses in the body. So there was in 2023, we published in Nature the sort of finding that so many folks with long COVID appeared to have EBV reactivation. But also I would just name that, just recently, this was about a month ago, Naderi and colleagues published in Future Virology this comprehensive list of all the other viruses that seem to get reactivated by a SARS-CoV-2 infection. So understanding why the virus has this ability to reactivate latent pathogens and understanding what we might do about that becomes really, really important. Is it really going to be our role to address every single pathogen with antivirals, antibiotics, antifungals, or do we need immunotherapies to teach the immune system to take control back? These are open questions that need to be addressed. I will only say one quick word on this because I know that Rob is here and going to give a phenomenal speech, but I always like to shout out to Rob and his team because this work is amazing, just showing that PEM, and he now has even more new and impressive data showing that PEM is not deconditioning. It is, it is a metabolic disorder. It is physiological, and it is causing symptoms in folks with IACCs. And in this Nature paper, he showed it very, very nicely that folks with long COVID, when they're put through exertional activities, amyloid proteins emerge in muscle tissue compared with healthy controls where that does not happen, because that is physiologically an abnormal thing to happen and indicates that we've got a metabolic system in trouble. We also know that certain hormones, including morning cortisol levels, are affected by SARS-CoV-2, and we see this in long COVID. So in our 2023 Nature paper, we showed that morning cortisol levels were, were significantly depleted in people with long COVID compared with healthy controls. When we started digging into the hormone story a little bit more, we also started to see that there are certain symptoms associated with gender in our cohorts. So certain symptoms would have a higher frequency if you were a male patient with long COVID, and certain symptoms would have a higher frequency if you were a female with long COVID. And some symptoms, yes, were common to both cohorts. So we started to dig into this, and what we saw was that that sex hormone differences seemed to correlate with those symptom differences that we were seeing. So in women, we were seeing lower testosterone levels associated with those, that sort of typical female long COVID presentation. In men, we were seeing low estradiol levels that were correlated with the male presentation. And interestingly, what we saw was the lower, if you were a woman living with long COVID, the lower your testosterone levels, the more severe the sort of sex-specific symptoms were. If you were a man living with long COVID, the lower your estradiol levels, the more severe your male-specific long COVID symptoms were. And if you were a man living with long COVID who had a hormonal pattern that looked like a female living with long COVID, you tended to have more female-specific long COVID symptoms as well. So it's not really about the gender, it's about the hormonal levels that we're seeing. So very, very interesting stuff, and really opens up some insights into actionable interventions, even if they're symptomatic only. We've been working a lot with Rhizia Pretorius' team in South Africa to publish on the endothelial dysfunction that we see in folks with long COVID. We run an endopat analysis on all of our patients who come through the center, and roughly 30% of our patients have severe endothelial dysfunction using the endopat, so diagnosable using an FDA-approved device for identifying endothelial dysfunction. But we also see many signs of subtle endothelial dysfunction, increased fibrinogen laydown, platelet hyperactivity, sort of clumping together of red blood cells and unusual red blood cell shapes and morphologies. So we do know that this sort of clotting pathology and vascular pathology is a hallmark of infection-associated chronic illnesses. This is one that we're actually, when it comes to the microclots, it's very interesting because it's one that we tend to see bigger and more prominent microclots in folks with long COVID compared to other infection-associated chronic illnesses. We think that that could be spike-related, and I think that that's a really good area to start looking into, because I think that spike drives a lot of these abnormalities in folks with long COVID. I finally want to sort of move into some of the neurological deficits that we can see. We published this paper in 2022 with some colleagues at Stanford and with Akiko's team, showing that even a mild acute illness can cause neurological damage through neuroinflammation. So what we saw was that this mild acute illness that we induced in mice would proliferate CCL1 and CCL11 levels, chemokines that would then go on to attack the central nervous system, even though the pathology never left the lungs of the mice. When we then cross-checked our human participants who had cognitive impairment, who reported cognitive impairment, we saw elevated CCL1 and CCL11 levels compared to long COVID patients who didn't have cognitive impairment as one of their symptoms. Digging deeper into pathology and pathobiology affecting the central nervous system. We also did this passive transfer study. This is some of the work of Kayla Sa, who's a grad student in Akiko Iwasaki's lab, where we purified IgG. And we then injected the IgG, passively transferred the IgG into mice. And the first thing that we saw was that the long COVID IgG was much more sort of reactive against human central nervous system tissue than the IgG from healthy controls or convalescent controls. But then what we saw in addition to that is, and we have multiple findings here, but I'm just going to focus in on one finding, because what we saw was that the passive transfer of this IgG can also influence symptom expression in the mice. So the mice would experience grip strength deficits, balance deficits, etc. One of the most interesting to me was the mice experiencing increased sensitivity to thermal pain. Not only did we see that the passive transfer would do that, but we only saw it when the mice received IgG from patients who also had new onset pain. The patients who did not have new onset pain as part of their long COVID symptoms did not seem to induce any increases in thermal sensitivity in the mice, indicating that we can passively transfer these symptoms as we're passively transferring the antibodies, really highlighting a role for autoantibodies in at least a subset of these patients. So my final comment as we move on to a day that I'm sure is going to be full of really amazing insights and talks and science is we also just need to, Akiko and I put this review up in 2023 where we were just talking about the need for understanding the dynamic nature of these illnesses. Infection-associated chronic conditions or illnesses, these are very dynamic illnesses. So depending on how long you've been sick for, depending on what cycle in your period you're on, depending on what sort of a day you're having, your physiology can look very, very different. And so a lot of these blood tests that we take and a lot of these deep phenotyping techniques that we take often need to be repeated over and over and over again for us to understand the clinical picture in just one person, and also to understand the cyclical nature of the processes that are really driving the symptoms. So I hope that this has been a helpful one and a helpful opening to the presentation. I just want to thank all of the wonderful people who actually do the work so that I can come here to beautiful Berlin and talk about it. But thank you all, and I think we've got some time for questions.
Thank you very much, David, for giving this great overview. Actually, we planned that for introductory sessions. We have not much time for questions, but as you were so well in time, we would have time for one or two short questions. Yehuda, please. Mm-hmm. Yeah. Mm-hmm.
Thank you very much for this wonderful overview. The question is why the virus is so effective in inducing such a panoply of manifestation in every organ. And I believe that we had a suggestion. We did molecular mimicry analysis, and we found that this virus specifically has enormous molecular mimicries with different organs in our body. Actually, we still do not know all the organs. Recently, we found that it can induce, due to molecular mimicry, antibodies against semen, thus can be responsible for low fertility.
Yep.
So, and it replaced actually EB virus. And interestingly enough, when we analyzed EB virus molecular mimicry and the COVID molecular mimicry, they had overlap in some way. But needless to say that the COVID has a larger molecular mimicries with our body. So I think that this may explain the different pathway that you have so elegantly described us.
Thank you. Yeah, and I really agree. I think in 2021, Amy Proal and Mike Van Alzecker wrote a really wonderful paper detailing all the ways that this virus has the ability to, seemingly a near unique ability to mess up our immune system on many different levels, from the spike protein that it releases to the way that it can alter interferon signaling and mess up our T cell responses and B cell responses. So there is definitely, but I think what we're going to learn now that long COVID has put a spotlight on this is that there are certain classes of pathogens like Epstein-Barr virus that are not dissimilar, and probably a lot of enteroviruses that can persist and cause problems systemically for a very long time.
Okay, thanks. So there are already several questions from the live stream too. And there's one question asking about the difference between long COVID and ME/CFS. And if you want to, I'm going to answer this question, and we switch places now. I overtake now.
Sounds good. All right. Well, thank you, everyone.
Thank you, David.